Hi there, and welcome to the first in the series of Talking with the Experts. My name is Kate Perkins, occupational therapist and lymphedema therapist and founder of Lymphatic Solutions. I have the absolute pleasure and privilege today of speaking to Louise Koelmeyer on the topic of early detection and intervention for breast cancer-related lymphedema. Louise is my inspiration for doing what I do today in breast cancer rehabilitation and my passion for early detection for breast cancer-related lymphedema. She has been an occupational therapist for over 25 years in the public and private sector, specialising in breast cancer rehabilitation and lymphedema management in all areas of assessment and early detection and intervention. Louise is also the manager or program director for the Alert program at Macquarie University Hospital. Have I got that right, Louise, with Macquarie University Hospital? Yeah. Alert stands for Australian Lymphedema Education, Research and Training. So I thought Louise is the best person to talk about this topic. She has been involved in quite a few research clinical trials, one being the Vanderbilt University clinical trial, looking at monitoring and early detection for breast cancer-related lymphedema. So welcome, Louise, and thank you so much for joining me. I know your time is precious, so I very much appreciate it. So thank you.
Thanks, Kate. I'm really excited to be here and really privileged to join your team, and proud to see one of our graduate students from our courses do so well and share the passion that I have in this area.
Fantastic. Thank you. So today, talking about early detection and intervention for breast cancer-related lymphedema, we've got two types of listeners that will be listening today to this series. One will be women who've been just been diagnosed with breast cancer and will about to undergo treatment, including surgery and related treatments. Women who are recovering now, as well as GPs, breast surgeons, radiation oncologists, and the breast care nurses. I think talking about this subject and educating as many people as we can on this topic in the hope that all women diagnosed with breast cancer will start a monitoring process. So first of all, simply, I just want to ask, what is lymphedema for our listeners?
Okay, so lymphedema, edema means swelling. It can be swelling in the arm or the chest, breast area after having a diagnosis of breast cancer where lymph nodes have been removed. So it's really develops a compromised system, and what the target of the model of care, I guess, that I'm passionate about is the early detection of what we call subclinical lymphedema, where we can try to pick up really early signs of this condition before we get full-blown symptoms of swelling in the arm. And that's where I'd really like to focus our attention on, really targeting early changes.
And how is that done? What technology do you use?
So I guess just before I answer that question, we know that these days 80% of women survive breast cancer treatment, which is really good. Our treatment and medical management of breast cancer has advanced so significantly in the last 25 years or more since I've been working in this area. I know I don't look that old, but what we know is that for those women who go on and develop the condition lymphedema, this can impact them physically, functionally, psychologically and financially. And so if we can reduce those impacts on their life, then they're hopefully going to get better outcomes. And for those who do develop lymphedema, we know that it's almost that daily reminder that they've had breast cancer. Absolutely. Because we know that one of the most common treatments and most effective treatments is wearing a compression sleeve or a compression garment. And we know that that garment is that first sign that other people can see when they're out in the community, whether it's out with friends socialising or in the workplace. As soon as someone sees that compression garment, it's what happened to your arm. And then the women themselves have to say, oh, well, actually, I've had breast cancer and this is a side effect of breast cancer. And then that can cause some real communication issues for the woman, both herself and also for the people talking to her. So if we can try to reduce some of those early symptoms, then hopefully we're going to give women a better quality of life.
Absolutely.
So as far as detecting early lymphedema, I guess there's different ways we can pick up changes in the arm, and really the women themselves who are going through this condition are the best source of assessment to know their own body. And it's really important that women have an understanding of their own body, how their body feels, so that if they feel changes in their arm, for example, symptoms of heaviness or aching or something's not quite right, then it's really good for them to go and seek assessment or referral to someone who can do a full assessment and to really be able to give them education about what's going on in their arm. Because after breast cancer surgery or breast cancer treatment, there are lots of side effects associated with the treatment. We can have simple things like range of movement problems in the arm. We can have scar problems that restrict movement. We can have some post-surgical edema, and often anything relating to the arm is considered, oh, that might be lymphedema, and it's often not. And we need to be really careful about how we talk about lymphedema. Even giving the diagnosis we need to be careful about, because the word lymphedema, once you develop clinical lymphedema, you're really living with a chronic long-term problem. And it's really my area of passion to try to avoid that and try to get back to the basics of let's support these women. Let's try and educate them in what are the signs and symptoms of lymphedema. Let's look at what are their risks associated with lymphedema, because these days, because breast cancer management's changed, women are at very different risks. And I don't think we need to give every woman the same level of education, because a woman who's had one sentinel node removed, some conservative breast surgery and some radiation treatment is at a very different risk for lymphedema to a woman who's maybe had 25 or 30 lymph nodes removed from their axilla, plus a mastectomy, plus radiotherapy, chemotherapy. They're at a much higher risk. So I think we need to risk stratify our patients and give them education according to their level of risk. And then implement, as you've already said, Kate, what we're calling an early surveillance, early intervention model of care, which actually starts right from the beginning when a woman's diagnosed with breast cancer, rather than waiting until someone's got a problem.
Absolutely. So, Louise, do you think that it starts from the GP? So, following that diagnosis, is the GP recommended to refer their patient on to a lymphedema therapist who specialises in the early monitoring program? Ideally, I would hope lymphedema therapists are actually linked already to a breast cancer multidisciplinary team. That would be your ideal model, that you have lymphedema already working as part of the multidisciplinary team. And we say that's the best model of practice, but it doesn't always happen. So women sometimes need to be advocates to say, hey, what's out there for me? Are you considering lymphedema as part of your package of care? Yes, I think we do the surgery well, I think we do the adjuvant treatments well, the chemotherapy and the radiotherapy, but sometimes we miss out on the holistic approach to the physical and functional and psychological rehabilitation after a diagnosis of breast cancer. And do you think at that initial consultation where we're taking measurements, so limb measurements and the L-Dex measurements, which we'll talk about in a second, at that time, providing those women with education around breast cancer rehabilitation and what's going to happen following their treatments, and education around risk minimisation for lymphedema.
Yes, very much education is a key component in the very early days. We don't have to talk a lot about lymphedema because at the time of a breast cancer diagnosis, women really want to know what's happening the here and now. What's it going to be the outcome of the surgery or the chemotherapy treatment that they're having? But developing a therapeutic relationship with an allied health professional and a breast care nurse to talk about the physical, functional factors associated with the treatment women are having is really important. And once you've developed that relationship, then you can give sort of, I call it a drip filtering of education. So over time, as the woman's getting through the initial intensive treatment, we want to give them little amounts of education about lymphedema, the things to look out for, the signs and symptoms, and the ways that they can live a potentially really healthy and fulfilling life.
Yep. It's the whole package, isn't it?
That's right. It's a model of care we're talking about. It's not just take some measurements to pick up early signs. It's really looking at a model of care, a package of care from the start to the finish, because some of the members of the multidisciplinary team only have a role at certain times when their particular intervention or treatment is happening. But really for the allied health and the breast care nurses, they're really monitoring and supporting women along the whole journey. And lymphedema is one of the conditions that can come up at any time along that journey, that treatment journey. And so we want to be involved and getting some really good data to be able to inform the women, to educate them, and really empowering the women. We want the women to feel like they know what's going on and are wanting to take control and charge. So really developing a partnership or a relationship, and that's what I say to my patients. Want to develop a partnership with you on this journey, and these are the things that I can offer you to help support and monitor your condition.
And I find those patients are the ones that are a little bit more prepared for what's happening after treatment.
Yeah, sure.
Yeah. So in terms of the early detection, going back to that other question previously, how do you do that?
Okay, so there's lots of ways that we can measure or assess for lymphedema. But if we're looking at this focus of an early detection model of care, then the technology that's internationally been validated and is considered reliable tool is what we call Bioimpedance Spectroscopy, known as BIS. It's a long word, but we can say BIS for short. I generally use the word L-Dex with my patients. That L-Dex is actually the reading or the unit that gives us a number. That's what we're monitoring the fluid in the limb. So what BIS does is it measures extracellular fluid changes, comparing the at-risk arm to the unaffected arm. And so what it's doing by taking ideally a pre-treatment measurement, so at baseline, at a person's diagnosis of their breast cancer, no matter what treatment they're going to be having, by taking a pre-treatment L-Dex measurement, then we know where their starting point is, because we then want to be able to monitor at regular intervals according to their level of risk, so that we can pick up any slight changes that then we can intervene early to try to prevent it progressing to clinical lymphedema.
And so talking about the monitoring phases, at what point do you implement preventative treatments?
Program, sure. So if I'm using the BIS technology and monitoring using the L-Dex readings, then if I've got a pre-treatment baseline, I'm looking at a change of 6.5 L-Dex points from their baseline as where I would intervene. Now, I'm also taking into account what else is going on at that time for the woman, but I'm wanting to be proactive, and I'm wanting to inform my patients that we're wanting to intervene early, and the most recent literature is telling us a 6.5 change in L-Dex points from their baseline is where we should be targeting for the best outcome. In the past, we actually had a higher variable that we were looking, a change of 10 points, but the research is really now, international research has shown it's 2 standard deviations from the norm, which means in research clinical terms it's 6.5 L-Dex points.
And so that was research that you've been involved with Sheila Reidner and Professor John Boyages
That's right.
and others. So that's quite a significant difference, isn't it, from the 10-unit increase and the 6.5 unit increase. So that would be something that we need to get out there to other therapists, wouldn't it, to implement that proactive approach.
That's right. So for those of us who have been doing this for a long time, we always said it was a 10-point change from baseline. But because of more evolving research over the last few years, the research is really saying that a 10-point change from baseline is potentially missing out on some patients that we should have been treating. And so really now the research is supporting this change, and that's then what we should be educating and promoting both to our patients and also to health professionals so that they're up to date with what the current literature is. And when the technology first came about, they considered a 3-point standard deviations from the norm as a good way of not getting two people anxious about, getting, changes. But now the research has really shown that with more international studies that we can pick it up confidently at a 6.5 change.
And the technology that you're using, the L-Dex unit that you're using, and that I'm using myself in my clinic, and I absolutely love. So that's the SOZO by Impedimed. What are the benefits? How are you finding that technology?
Yeah, I'm loving the new technology. I had used the previous technology for about 12 years, and I really found that a useful tool, and it was just part of my routine practice and loved using it, and saved all my data for 12 years of seeing patients. So I have a lot of data, but I was actually able to transfer all of that data into the new SOZO device.
Yep.
The advantage of the SOZO is that you can sit or stand to do the measurement rather than having to lie down. You don't have to worry about electrodes because they're built into the device, and you can set the baseline. You can be monitoring for both arm and leg lymphedema if we're focusing on other cancer groups, and also unilateral and bilateral lymphedema. So with the previous device, although you could monitor for bilateral lymphedema, it was a little bit harder. But now if a woman's at risk of both sides having lymphedema, then you can certainly put that information into the device and it can calculate the reading for you. So it's probably just streamlined taking the measurement, made it quicker, and it also has other advantages of being able to do full body composition measurements.
Yep.
And that is a really exciting part of, I think, our practice now. When we're looking at monitoring women over a period of time, we know that often women gain weight while they're going through their breast cancer treatment, and sometimes we don't know, is that because the women's taken on your advice and education to try to be really diligent with exercising while they go through their breast cancer treatment? So in fact, the weight that they've gained is actually muscle mass, which is a really positive thing that our body needs. Or have they actually changed their lifestyle, that they're not exercising, their metabolism slowed down, they're having more cream buns and coffees out with friends because of the treatment they're going through, and in fact they've actually put on a large proportion of fat mass in their body. And obviously as we all age, go through menopause, our body shape changes, our body composition changes, but as we do get older, we need to be really focused on not increasing to maintain lean muscle mass. We want to be hydrated, which is really important when women are going through cancer treatment. And this information can all be given to you by the press of one button and sort of 20 seconds in being able to take a measurement.
And now,
the women love it because I email them their readings, and then again, information is power. Women like to receive the information so that they feel like they're taking control and managing their own condition.
And we can also share that information with the whole medical team. And
exactly.
So the whole medical team are on the same page, and they know where it's at.
Yeah, and particularly lymphedema sits under what I'd call that survivorship area of breast cancer, and it's not just lymphedema that happens at the end of treatment. There's all other associated issues and side effects from breast cancer treatment. You know, some women have the peripheral neuropathy, other women have joint aches and pains, extreme fatigue, body image issues. There's sort of a whole lot of things that happen in that survivorship phase after the intensive phase is finished. And so having some good information that shows change from before treatment to the conclusion of treatment makes it easier to educate and to target how you might encourage or motivate someone to take steps to maybe reduce weight loss or increase exercise, and give feedback, individualised or personalised feedback.
Absolutely. And that weight loss is important in terms of increased fat mass is a risk factor for developing lymphedema. So we can closely monitor that as well.
That's right, and that comes into our risk stratification, that women at the time of diagnosis, we can stratify them into high or low risk according to a whole lot of risk factors. And certainly a high BMI, body mass index, has been one of those factors that we've known that can potentially put you in that higher risk category.
And knowing that the SOZO can measure both limbs at the same time, arms and legs. So the same principle applies then for melanoma treatment, melanoma surgeries.
Yeah, so it can be for all solid tumour cancers. So melanoma, gynecological cancers, which previously was harder to use the bioimpedance for because, you know, often that cancer treatment is associated bilaterally in the pelvis, prostate cancer in men, and of course breast cancer.
It's fantastic. I love it in my clinic. It's a great addition.
I'm actually testing it at the moment as part of my PhD studies, looking at home monitoring for women. So I'm putting some devices in women who are at high risk for developing lymphedema 3 months after their breast cancer diagnosis, and I'm getting them to monitor at home in between their quarterly clinic visits. And so the women are really enjoying having that additional information and taking charge of themselves.
That's brilliant. That's brilliant. And Louise, you were talking before about the data that you've collected over a number of years. What patterns, what outcomes have you seen from that data collection?
So I'm quite excited by this data. I'm actually just writing it up for publication at the moment. So hopefully someone will like to publish it to be able to share the information with other people. So I did what we call a retrospective review of 10 years of clinical data from me, seeing women going through breast cancer treatment. There's about 750 women that I went through their files that I've seen personally over the last 10 years, using the one device to monitor them for lymphedema, the bioimpedance device. And what I did was I ended up dividing these 750 women into 2 groups. About half of the women I saw were referred to me at the time of their diagnosis of their breast cancer, or within 3 months of their diagnosis. And I was able to then look at that group as what I've called the early surveillance group. They came to me early and we started monitoring them and giving them that whole breast cancer package.
Yeah.
The other half of the women that I reviewed is what I would call my traditional referral group of women. So these are women who came to me greater than 3 months after their diagnosis of breast cancer, and they were referred from what I call St. Elsewheres. So they had their treatment in another hospital or centre, and they were referred to me because they may have asked a health professional about questions about lymphedema. They may have noticed some symptoms relating to lymphedema or breast cancer physical management, and they were referred to see me. So the really interesting finding comparing these two groups of women, even though they weren't exactly the same because some came very early and some came very late, but those that came in the early surveillance group had significantly less incidence of clinical lymphedema.
Right.
And for those who developed lymphedema, they primarily had the stage 0, stage 1 lymphedema, as opposed to the traditional referral group that predominantly those who develop lymphedema, and more developed than in the early surveillance group, but those who develop lymphedema had significantly more moderate to severe lymphedema than in the early surveillance group. So that was my sort of gut feeling that I was doing a better job. I wasn't doing as much intensive physical hands-on treatment that I was doing previously.
Yep.
And the data actually showed that. So yeah, we're really pleased to be able to present that data, that hopefully other people will be able to see that this is real clinical data. There's limitations with that, of course, I understand, not being a big randomised prospective study, but the fact that it showed that those women who came earlier had less incidence of lymphedema and less severity of lymphedema, which is what my patients all want.
Absolutely. And for those patients in particular, the number of visits to you and treatments completely significantly reduce the financial impact on their post-breast cancer treatment.
Yes, and certainly the health economics financial side of visits for early intervention versus the traditional referral model of care is certainly something that governments and health fund providers are very interested in. There are some studies internationally that show providing early detection and early intervention is less costly to the health system. My data, I wasn't really able to analyse that in full detail, but certainly I'm aware that those who went on and developed clinical lymphedema do take more resources and more time to manage the clinical lymphedema. And the other thing to think about is just the costs of living with clinical lymphedema versus subclinical lymphedema.
Absolutely.
In that there's many more people who end up with admissions to hospital with cellulitis needing IV antibiotics. You've got time off work when women have cellulitis episodes, and those with clinical lymphedema need the much more intensive therapy, so they need bandaging periods, and they often need the much more complex and expensive compression garments. So if a woman has both hand and arm swelling and significant swelling, they generally need a custom-made compression garment and glove, which can cost about $500 to be custom made for their arm. And generally we say you need 2 garments every 6 months, as opposed to someone who has subclinical lymphedema, which to visually look at the arm, we don't see a change. The tape measure doesn't show a change, but the L-Dex may be a little bit elevated. Yeah. And for those women, our intervention is wearing a ready-to-wear compression sleeve, and they cost about $100. So there's a significant difference in cost, and I think we should be looking to try to develop an Australian prospective study where we can really compare the costs associated with early detection and early intervention versus that traditional referral, wait until it develops clinical lymphedema.
So that's where we need to get the education out there to the GPs and the breast cancer specialists at that level.
Definitely. Definitely. Education is important. We need champions out there. We need women going through the condition to lobby their multidisciplinary teams, that you deserve to be educated to evidence-based information. What we know, we didn't know this information 10, 15 years ago, but now we do know it. It's a bit of a no-brainer. If we can take a measurement that lasts less than a minute to do and give you some really pertinent information that requires less invasive treatment, I know I would much prefer that myself, to be not living with this chronic condition that's that daily reminder of the fact that they've had breast cancer. So lobbying your doctors, lobbying your healthcare teams, lobbying your health funds to be able to fund programs of early detection and early management is really the key.
And I think that is the perfect sign-off for this topic today, because thank you so much, Louise. We've covered so much and it's been extremely informative. And I'm looking forward to sharing this with our listeners, and I think they would find it quite valuable. Do you have any final messages for our listeners today?
I would just say to women going through breast cancer treatment, you can make a difference in hoping to reduce the incidence of lymphedema. Tap into a local therapist who's really on board with this model of care and really spread that message. And there shouldn't be any activity that you shouldn't be able to do because of you going through your breast cancer treatment. Get active. We know exercise is such a key activity to do in supporting the education we've talked about, to supporting the monitoring we've talked about. Keep active and be aware, and good luck with it all.
Brilliant. Thank you so much, Louise. And thank you, everybody, for listening for the first in the series of Talking with the Experts. And I look forward to bringing another episode to you soon, and stay tuned for the topic. So thank you very much.